Thanks, Liz. I so appreciate you and welcome everybody. This is Module 3. Some of you are new and just joining us, and we're glad. If you're interested in the previous 2 modules, they have been recorded and archived, and you can go back over them. Our theme is Come to the Table as we consider all of the ways that we can come as clinicians, as administrators, as community health center folks, as families, and as members of the community to address healthy weight in our nation's children. Next slide. Today, we have a special couple of chefs joining us to create their own entrees for us, and we have Dr. Rick Greifenberg. He is going to be talking about a special clinic that he runs regularly for both adults and children with overweight and obesity. And you've heard my voice a lot. Jessica Wallace, our friend from Denver, is attending too, and she helped us find Adrian Center, physician assistant, who is also going to be sharing a special program that they do around medical management of children with obesity and overweight. So we'll have 2 folks from the field in the community health center movement who will be able to give us real life, in-depth examples, and we will have time for questions at the end. Next slide. So today's about medical management. I kept saying in the other 2 modules that we're going to get to that exam room. And so today we're pretty much in that exam room, and we want to choose the right utensil to keep our metaphor going. So do we need a spoon, a fork, a knife? What do we need at our table? We're going to talk about that. We'll start with meaningful work as usual, and we'll go over different ages and stages. Our food is all prepared in-house this time, so this is all about what we actually do in the health center, although we will have as part of our medical management when we should refer out to a specialist. And our next module is on community, just so you know what's coming up. Next slide. As we gather again now, Module 3, we want to take time again to acknowledge that all of us come from a vocational setting where we're givers and where we're passionately interested in the health and well-being of our communities and our children. And I know there's been lots of forces working against that that we've experienced in the last few weeks, if not the last couple of years. So today, let's spin it into something positive. Too often we're told what aspects of our work people don't like. I'd like you to really focus on what aspects of your work you're really proud of. What just brings you a lot of pride? And I want you to think about that for a second. Who notices that? Hopefully at your workplace. And if not at your workplace, where is that noticed? But particularly at your workplace. And what motivates you towards that, especially when maybe you're not getting as much positive affirmation as you might deserve. So how might you encourage your patients who struggle possibly with weight management? How might you encourage your families, your patients through understanding their strengths? How might you notice better the things that your patients might be proud of and might actually be doing well? All right, I hope these moments are helpful for you as you go forward and towards your colleagues and towards the families you serve. Next slide. So spoons, forks, knives, what do we need? We're going to talk about prevention a little bit. We covered a lot of that in Module 1. Today is more on when we need to intervene across age groups. So the spoon is the easy part, right? It's just that's what we do as babies. So we're trying to do a lot of prevention with the spoon. And then the forks and knives are a little more complicated. As we mentioned before, some of this will be a review if you did module 1, but we need to hear it over and over. A healthy weight for ages 2 to 18, we don't really do BMI under 2, is considered a BMI of less than or equal to 85%. And overweight is an area that we get concerned about. That's where your BMI is 85 to 94%. And then obese is over greater than or equal to 95. Severe obesity is over 120% of the 95%, which again sounds so complex, but it's not really. And we'll look at slides again in a second. So we want to remember to use those CDC age and sex specific growth charts. We want to remember to do a lot of QI around whether we're accurate. We want to repeat as we need to. And importantly, we want to document in our EHR somehow so that it's retrievable. If you want to do a QI audit, that you can retrieve how your pediatric population falls in that, but also on a particular child that you can very quickly, as you're seeing them, notice in the problem list as well as in their growth chart what the trend is happening, whether it's increasing, stable, or decreasing. Next slide. So again, we had this slide in the first module, but it's here again for you since we're focusing more heavily on it. And that is what the growth charts look like for BMI. And you can see up in the red zone, that would be a child who is in the obese category. The yellow zone would be the overweight category. The green is healthy weight, and the below is malnourished underweight. And then a pullout to show you what severe obesity looks like. And that pullout allows you to make it more of a gradient rather than just severe obesity. Next slide. So we talked about algorithms previously, and we showed you our own that sort of NAC has developed of a care cascade. It's not the same as an algorithm, but it was pulling out prevention and then treatment, intervention, and when to do labs and specialists and that sort of thing. This nice one-pager is the algorithm the American Academy of Pediatrics has put together for children 2 and older. The huge caveat is that it's been under revision for a while. The date has been moving about when it's coming out, but we are expecting the new version in the fall of 2022. So we don't think it's going to be dramatically different, but it will be different. Meanwhile, this is the standard that's available to you. And again, it's for 2 years and older. When we look at intervention kind of algorithms and the healthy lifestyle intervention that requires 26 hours of time and focuses on nutrition, physical exercise, medical, and lab, that's traditionally been 6 years and up. So this is looking at 2 years and up. The new guidelines are moving more towards prevention, so that will be more of a focus, which I think is great. Moving down in the ages of interest and remembering to focus on the family and on health. And that's what we've been trying to emphasize. So here on this pediatric algorithm, we have healthy weight, overweight, and obesity, and pretty much the routine care that's expected with the first lab screenings, and Dr. Reifenberg is going to go into that, and some of the obesity related conditions at the bottom that we're going to talk about in a minute also. Next slide. So comorbidities, people have asked about this in the past, and again, when we look at guidelines that are printed and accessible for your use right now, the age and BMI related comorbidities that have actual statements about what you should do and which labs and all that sort of thing are these 5 here: hypertension, diabetes mellitus type 2, prediabetes, lipid abnormalities, non-alcoholic fatty liver disease. when we look at these are basically for ages 3 and up is where these start. And I was saying to our colleagues before we started that today's Monday in the news, important news that started out from the American Academy of Pediatrics newsletter was that studies show that not only is type 2 diabetes prevalent in people who have obesity, but also now in adolescents with overweight and obesity, we're seeing a much higher risk for type 1 diabetes than we would expect. So usually we think about as, younger children, but we're seeing type 1 develop. Next slide. So other comorbidities that we see that don't necessarily have specific detailed guidelines, but that are associated comorbidities that go along with this that we want to be on the lookout for. Asthma, we have been talking about mental health concerns, and that's right now, that's in front of everybody all the time. And our adolescent girls, polycystic ovarian syndrome and thyroid disease, sleep apnea, which then affects development, affects school readiness and health. And then obviously some genetic abnormalities. And I had somebody that I mentor in Hawaii, she's a nurse practitioner, asked me last week by text, could a child with obesity have constipation bad enough that she had some rectal bleeding? I said, yes, constipation is a big problem in these children. And often you can't palpate that well with a child with significant obesity, but it's a huge problem. And then I've seen several adolescents, and well, actually, they were more like 11, with slipped capital femoral epiphyses, SCFEs. Next slide. So what we're going to go into again here as we go into management around ages and stages is we're looking at sort of 3 groupings. They bleed into each other, but the minimal age that we're looking at intervention beyond weight and counseling is age 3 and greater, and that's when you want to make sure you are getting a blood pressure, screening for hypertension, and you may do lipid screening in children with obesity who are over 3. Sorry for that person first language that is missing on that slide, but I'll see if Adrian and Rick agree with that or not. Age 6 and over, we get more opportunities, hopefully, around health and behavioral lifestyle intensive treatments, and try to get that family-based treatment that involves more than 26 contact hours over 2 to 12 months. Why? Because that's the evidence base. There's nothing magic about being 6, but that's where the programs got started, and that's how they're pretty much for school-age children, that's how they're run. And then age 10 and greater, if they have obesity, so we're not talking about overweight at this point, we get into more of the adult-oriented studies. Okay, next slide. So severe obesity or obesity with comorbidities, some of you may not feel that that's really your bailiwick, and that's okay. It's just you need to know when to refer. So we want you to feel comfortable with knowing that this is the point at which this child needs management that's more sophisticated than I can offer. And bariatric surgery, some of you might be surprised now, doesn't have an age limit on it. We used to really avoid that in children and even adolescents, and now there's good evidence to show that it's helpful and worth the risk in certain situations. And I'll let, again, Dr. Reifenberg might talk more about that. Next slide. Yeah, no one in Utah will do under 18. Some of that's a provider issue, just like who's available. Sometimes it's also insurance. A lot of times insurance makes you prove, and that's been seen very clearly in adults as well. You have to prove that you're failing lifestyle. when what happens is they just gain more weight and have a longer time of developing more comorbidities. So there's a lot of pressure to change that. Now we're going to pivot because this is going to be the really fun, interesting part for all of you. I was kind of like the teacher at the blackboard, but telling you your notes that you should take. But if you want to really see how this gets lived out, we have some wonderful folks with us. Dr. Rick Reifenberg, I met through the American Academy of Pediatrics section on obesity communication, and he is a physician and the chief medical officer at HealthNet Community Health Centers in Indianapolis. And he does run his own clinic that he'll tell you about. And then Adrian Center has is a physician assistant at Brinken Medical Center in Miami. And Adrian has been working with the National Association of Community Health Center as a participating health center colleague on pediatric weight management programs and initiatives and innovation over the past few years. And we're delighted to have both of these folks. So I'm going to turn it over to Rick.
All right. Good afternoon. Thanks, Jenny. So yeah, I'm Rick Reifenberg. I'm a internist and pediatrician. I've worked at HealthNet Federally Qualified Health Center for the last 22 years. I did primary care for the first 10 years or so. And in these last, I guess, 12 years now, have done medical leadership and still do clinical care. And what the way I got into this is it was an area that I was always interested in, health and wellness anyway. And, you know, when I'm only seeing patients a half a day a week, which is what unfortunately all I can do in my current role, it was a perfect opportunity to devote my time that I did have clinically to caring for children and adults who have weight-related medical problems. So that's what I do in my clinical time. I will say that I am not a researcher. I'm not an academician. I just do this in real life. So I think what you're going to hear from me today is, you know, what my experience has been over those last 10 years. And, you know, hopefully that will help. You know, I do see adults too, and in my program, it's probably just slightly more adults than kids. So I'll say that, you know, because of some of the things we do in adults, I'm more comfortable with doing those same things with kids as well. So you may or may not feel comfortable doing this, but as I go through my slides, I'm going to talk fairly quickly just because I want to cover as much stuff as I can, but I'm really going to try to focus on what I think are the most practical real world things. And I know when I watch, you know, sessions like this, I'm always looking for like, what do you do in real life? Well, this is going to be real life. So you can go to the next slide. And I think that's just the header information. You go to the next slide. Just real quickly, you know, Indiana is right there in the middle of that blue. Those are the highest overweight and obesity rates in the country, and you can see it surrounded by other, you know, the other states. That's that classic kind of rust belt that has so many other medical problems associated with it, and we're you know, smack dab in the middle of it. So that was that. You can go to the next one. So growth charts, of course. Now keep in mind, so I work at this large federally qualified health center. We have like 9 health centers. So all the patients that I'm seeing are being referred from other health center physicians, right? So this is an internal, you know, I'm not an endocrinologist. I'm just a primary care doc who has developed some knowledge in this area. So when I see patients in this program, you know, I'm seeing patients who have already been identified by somebody else. So keep that in mind. It's a little different than the primary care. I'm not screening people. I mean, they're coming to me because they're wanting treatment for this. So this is the growth chart we're all familiar with, and it's kind of like the, you know, you see where the growth chart is, you see where the child is. It's kind of like was already bad and getting worse. Does this look familiar? It probably does to most of you. Common things being common, you know, when you see obesity, it's almost always primary obesity. Go to the next slide. In 10 years, I've had one case that wasn't primary obesity. You're always looking for these exciting things. Here's only one. On the left is weight, on the right is height. And you see somewhere around for that child, somewhere around 5 years old, suddenly their height just stopped going up and their weight started shooting up. So you got weight going up, height not going up. And so this ended up being a child who had hypothyroidism. And they went to an endocrinologist. They started to get treated for it, and it, magically was helping these things. As it turned out, the child still was obese, and then I helped out with the final part of it, just doing the lifestyle things. So yeah, this is very rare. The takeaway point from this is excess nutrition always maximizes your growth potential. So, if you see that child who's, way at the very top of the growth chart, they're almost never going to have hypothyroidism. So I don't always check the thyroid, but anyway, interesting case, but that's not what you mainly are doing. Next slide. So this is the program itself. As I said, I started about 10 years ago. I see patients, from 4 up to my oldest patient, I think, was 77. We do an intake visit when we see them, which is a longer visit. And then I try to see them monthly for at least 3 months. And I tell them I want them to commit to coming at least monthly for three times, and then we see after that. And I've had patients I've been seeing now in this program for over 10 years. But I give them the choice if they want to go back to their PCP or not. The common comorbidities that I see, this is right off of what Jenny was showing you just before. And when you look at it, you see, if you kind of lump it together, you see the metabolic syndrome stuff, right? That's all those top couple lines. And then you see the behavioral health part, right? The depression, anxiety, victim of bullying, eating disorder. I mean, that is really common. If I spend the time to ask about it, the answer is almost always yes to one of these things. And then the last part is kind of the other miscellaneous things. So not so much in kids, but certainly in adults, you get into all kinds of orthopedic problems, the fatigue and non-specific things like that, the OSA, which is very, present in adolescence as well. PCOS, and again, in adolescence, you're starting to see the girls with secondary amenorrhea, things like that, and fertility issues. So the adults that I care for, that kind of 20 to 35 in often just postpartum is a really common one that I'll see, but also those who are, starting to have fertility issues. So those are the common things that we see. You can go to the next slide. And then, so when we actually see patients, so what do we try to do? At the very beginning, remember, I don't have to do the motivational interviewing in the sense that they're already there. But I want to find out, the very first thing we ask them is, you've come to this program, what is it that's important to you? And it does surprise me how many people, even though they'll say, I'd like to lose weight, they actually, there's something else. We're trying to avoid, we've got this family history of this, and in adults, there's often things, just related to, being able to do things with the kids, or energy level, or things like that. So, what I really try to, and I write it down, this is what you told me you wanted to get out of it. And at the bottom, and we'll get to that later on, we'll of the note, we have their goals, and we print those for them. And the goals are some of the things they told me, plus then I'm going to say, I want to add to your goals. And then, we're going to give them specific things to do. So that's a really important part of it. Then we do, our history stuff. We do the normal, measures that you're doing, usually with adolescents who are probably around 15 or 16, and then up to adults, we start doing waist circumference. I find it not to be helpful in younger kids as much, but certainly in the older and in adults, that's something that often hasn't been done. But when you work with somebody for a while, then often at some point their weight, they might stop losing weight. But when you're able to show them, hey, you have lost 4 inches too, that can be really powerful to them. And you remind them that central obesity is where, the bad extra weight really hangs out, because those are the things around organs, et cetera. The labs that we do, oftentimes the primary care providers have already done them, so I'm not going to repeat labs. And the nice part is we're all in the same system, so I can see them already. But if I do labs, a comprehensive metabolic panel, or if you wanted to be more specific, you could just do like an ALT or AST and glucose. Lipids, A1C, thyroid, I don't always do. Some of the other labs, I only do in special cases. So that top row would be the most common ones that I'm doing. I did have one child, I was like, oh, this one's gonna have Prader-Willi syndrome. I was so excited. I looked up the test and found it and ordered it, and they didn't have it. They just had primary obesity, but I thought I was excited for just a minute. You notice I don't have vitamin D on here. I have kind of a skewed opinion on vitamin D. I think vitamin D is an abnormal lab that's looking for a disease to attach itself with. So I don't even test it. I think, you know, if you have rickets, it's good. Otherwise, unfortunately, what I find is a lot of people have low vitamin Ds, and then you replace vitamin D. It doesn't seem to affect anything other than their vitamin D levels a little higher. So I won't dwell on that, but it's not one that I normally check. We're fortunate we have a registered dietitian. And by the way, dietitian is spelled two ways, either a T at the end there, or there's two T's. The second one can be a T or a C. Why am I even saying this? Well, dietitians like to be the two T's. That, you know, grammatically, and if you look it up in a dictionary, those are two spellings. But if you have a dietitian, they want you to use the two T's. So be respectful to them. That, you know, that goes along with the actual degree, registered dietitian. So two T's. Nothing else you can say you learned that today. We have a program booklet that we put together, and Jenny, if you want, I'll be happy to share it, you know, to you, but it's something that we use. It's for adults and kids. It's about 20 pages long, but it has a lot of general information. And then at the end, of course, we're creating a very specialized you know, list of things just for that patient. So the program booklet's general. Then we created this monthly health and wellness email, and we do this, we use Constant Contact to send it out. When people come in, we say, hey, do you want to be on our monthly email distribution list? So it's cleverly entitled Dr. Reifenberg's Health and Wellness email, and you can see it right at the bottom of the screen there. So the one for June that we just sent out was about carbs and heart health. But so it's a nice way for me to be able to continue to be in touch with them. So I have some medical subject, usually an article out of something that I find, you know, and again, I don't do articles out of journals. I do like articles out of the newspaper, articles out of magazines, because, you know, like people can follow that. Now there'll be reference to like real academic articles, but I find that they can read those at a much easier level. So that's good. We can go to the next slide. This is probably the most informative slide, so I'll spend probably the most amount of time on this. But so, you know, after doing this for 10 years, I do feel very comfortable that I can say you can do weight management type things and care in your own practice, you know, in a community setting. You know, in my case, the fact that I do this, the other providers in my offices can utilize me as, you know, it's easier to see me than to send the kid to the academic health center. We have an incredible one in Indianapolis, Riley Hospital for Children, you know, one of the top in the country, but they still have to go down to this big academic health center. They got to park in a parking garage. You know, they have a nice program, but they have to, you know, they have to go there and do that each time. So this has been nice for the patients who don't want to do that. What I have found in real life, though, is that retention can be a major issue. And actually, what I'll say the biggest issue is, you know, there's only one of me, so sometimes people have to wait to get into this program. So the no-show rates, at least for first patients, for first visits, tend to be higher, you know, probably 50%. So I'll just be like, you know, very, very, you know, upfront about that, because oftentimes they talk to their provider like, oh, this sounds great, but then, you know, maybe they're not really interested a month or two later when it comes time to come see me. So with that in mind, we actually double book our new patient, our new patients. We always have two together. And if they both come, and that happens sometimes, then the dietitian sees one, I see the other, and we switch. So that works out well. But she sees every patient, every visit as well. So again, that part works out as well. A lot of FQHCs do have dietitians. You know, you can't, but, you know, going to the next slide, you know, or excuse me, not the next slide, the next point down there, billing. So, we haven't had any issues doing billing. We do these all under just standard medical diagnoses, so you use the codes for obesity, elevated blood pressure. It's rare that I don't have at least one other thing, for every patient. And for adults, I might have 5 other diagnoses, but, all things that are weight related. But even with the kids, there's often something else that we're doing. We're using standard codes. We have not, Medicaid is about 70% of our patients. The other 30% is about half self-pay. The other half have commercial insurance. To my knowledge, we've not had any denials at all. We don't bill for the dietitian because, a lot of times, federally qualified health centers either have grants or other things to have their dietitian. And this dietitian works throughout our system. It's just this half day a week. It's just her and I working together. So that part's worked out pretty well for us. And then as far as medications, and let me, I do use medications in my practice. I use them a lot more in adults than I do in kids. But let me just give you some general things I'm going to tell you in this part. Number one, FDA approved and indicated does not equal covered by insurance. And in fact, some of the absolute best medications that are out there, I can't get, at least not in the way that they're indicated, but we have to get creative and we find ways around it. So what I'm going to tell you is that what you see in terms of the meds I am going to show here, you'll notice there's some ages listed after them. So like topiramate, greater than 2 years old. What that means is, all it means is that there is a indication for topiramate, in this case seizures, for 2 years and older, phentermine 16 and older, GLP-1 agonists, and there's a bunch of them, but Victoza is an example, 10 and older, metformin 10 and older. But again, the indication may or may not be obesity, but there is an indication. So a lot of times what I found is when I do end up using medications, I will tell the patients or tell the family, like, we're going to be using this in an off-label way. And I have a whole thing a paragraph that I've written that gets put in there that just says, here's what we do know about this. Here are the risks and benefits. And, do you want to use this medication? So the ones that I have used when it comes to kids, usually it's an older adolescent and above that I have used medications. And so I have used the top 2 meds that are listed there. The GLP-1 agonists are wonderful, and they are the most effective medications that I'm aware of. They're also the most difficult to get. If you are an FQHC, at least in our setting, we can get Victoza for self-pay patients at $15 or something, which is great. The problem is anybody else who wants a GLP-1 agonist has to have diabetes, and you have to go through a whole process and ways to get it. I have not been successful getting Medicaid to pay for it for anything other than diabetes. So even though it has an obesity indication, I can't get it covered. Vyvanse has an indication for binge eating disorder. Again, Vyvanse is indicated at 6 for ADHD, but not for binge eating disorder till an older age. But I have used that in an adolescent. I put the line on there about make sure patients on ADHD meds are compliant with them. I just recently had a patient, like a teenager, who was supposed to be on Vyvanse. And in fact, I asked them about it and they're like, oh yeah, we stopped taking that a while ago. And like, was it helpful? The child, the adolescent said like, yeah, I did better in school. It's like, well, okay, in this case, why don't we restart it? Like, I'm not just, pulling this out of the air. They really had a diet, so it's like, this will be helpful. And guess what? It was helpful. So again, don't forget about things like that. And then finally, in the adults in diabetics, there's a whole discussion about, which medications you use. And I'm not going to go any more on that. So anyway, so hopefully that's helpful for at least some thoughts on medications. You go to the next slide. And the only thing about this is if you're a real world provider in real life, what happens is, when you're doing primary care and then you're leaving the room with your hand on the door and they're like, oh, by one more question, just like, how do I lose weight? So that's how this happens in real life. You can go to the next question. So if you're primary care. So what did I do when I was in primary care? I had a simple handout for kids, and in fact, it's the one you see right there from the AAP. And then I had one for adults, and when I had my hand on the door, I'd say, if you're interested in losing weight or being healthier, take a look at this handout, and then if you want to come back, we could have a whole time on it. And that seemed to be pretty effective. You can go to the next one. So just some more summary things, and I'll just go a few more minutes and then I'll be done. So, especially in primary care, asking for permission to talk about it. Hey, today I would like to talk to you about the, as I look at this growth chart, I see some things with your weight and height that makes me think that this would be something that would be helpful for you. Are you okay talking about it? However you want to, put that, but that's helpful. Look for iatrogenic causes. Is there some? I always look in the charts like, what meds are they on? What else are they? There's often something else that maybe we can do something about. And of course, the behavioral health meds. Not that we're going to stop them, but it may well be that there might be another choice for something. So always looking for other things we can do. The first intervention, as I said, like a simple handout or something, because what you find is then you don't waste a lot of time talking to somebody who's really not interested. But by doing that simple, like, here's something you could think about, you come back if you really want to do this, then I find like the ones who come back really are more interested. Dietary history, you can see some of the things. We're very specific. We have in our template, it's all these different questions that you ask. And what I find is, if you just ask, tell me what you eat and drink, I find people they're not trying to minimize, but they often will miss things. And so what happens is this way, we kind of ask these same questions again and again. And by the time we get through them all, some of the things they forgot about, we usually have hit. So that's really helpful. And then the bottom part, as I said, specific, realistic goals. Again, they told me what they wanted, so I put that right in there. Whatever it is they told me, I put that in there. Plus that I'm going to add. Now, in your case, the 12 Mountain Dews a day is really going to be, if we don't fix that, we're not going to help you. So I'm going to give you this goal of, switching that over to something non-caloric. So that's kind of how we do that. The next slide, I think this is the last one, is then in our program, again, we give a very, we have a very specific eating plan for that patient. That's going to be our program is mainly a low carb, trying to avoid processed foods. It's not a no carb. It's not a keto per se. It's a lower carb. In adults, a lot of times we've used intermittent fasting, and that helps some people. But the standard things in this case, we don't do anything that's especially unique there. In the exercise part, everybody gets a very specific, wherever they're at, they're going to get something. In kids, it's pretty easy because it's usually like, hey, mom, dad, we've got to find a way to get 60 minutes somehow spread throughout the day, of them being active. And we actually, I love, since everybody likes their screens anyway, this is a chance to let's use them in a good way. So, we in the room will often pull up YouTube and look up some videos, and that gets them involved that way. We do give out, I buy jump ropes, in packs of 8 from I get them on Amazon. They're not that expensive, but they're multicolored. The kids love, it's like, oh my God, I got this. They're actually pretty good jump ropes too. They're not that much. I also buy some other inexpensive things, but it's like, hey, do you have a jump rope? Or they say they like soccer. Do you have a soccer ball? I give them a soccer ball. It's like, it's not that huge of an investment. But that makes it more fun. The medication part, again, it's, there's specific indications, but that have to do with BMI and comorbidities. But in general, when we do use them, the idea is they should be at least a 5 to 10% weight loss to be considered effective. I certainly have referred patients for bariatric surgery. I'm trying to think, I have not had an adolescent yet that I formally referred for bariatric surgery, but I've certainly talked to some families about it, and nobody was quite ready to go. But somebody, who's really high on the BMI and has all these comorbidities, I don't have any problem at all doing that referral. And I think it's easy to justify. And then the final thing there about at the end, I'm trying to get them to commit into this, plan the same way. So And I think that's my last slide. The last one is just an information sheet with my contact information. So I'm happy to talk.
Thank you, Rick,
there.
very much. Before we proceed to Adrian, I know both of you could have, we could have doubled the time here, but I do want just quickly,
Sure.
Are you tracking your outcomes over time for your weight management program, Rick? That's a question that I think.
That's a good question. Remember, I said I'm not an academic person. However, I have an EMR. So I did ask them to create. So the way that I was tracking, and I'm going to have to get more, I've got all the data there. I used it. It was much easier to do in adults than it was in kids. Because remember, kids may still be gaining weight, but it's okay if they're growing, and their BMI is doing better. In adults, it's easier because, you're really looking at pounds. So what I can tell you is what I found is that if I could get, here's the data I do have. In the last 10 years, I've seen, we've had 500 to 600 unique patients. For the patients who came usually they had to come 3 or more times to be able to show a real improvement in things. In other words, what you do is you select out the patients who are really, committed to doing this. Of the patients who came 3 or more times, about 3/4 of them lost weight. And of the adults, at least, the average weight loss was somewhere around 12 to 15 pounds. So that's the data that I have. I'm just
Okay.
throwing that out.
Thanks. And then real quickly, do you
Yep.
use any certified health and well-being coaches? And then Adrian, you can answer that too as you go.
Yeah. So in my case, I have the dietitian, but I don't have any other certified coaches like that. I myself, because I had an interest in it, so I'm American College of Sports Medicine certified athletic trainer physical trainer, I guess I should say. And so just because I wanted to learn more of so I do have that part to go with, but it's, I'm really just trying to come up with practical things for each patient.
Well, thanks, Rick. I'm sure we'll have more questions, and I'll just speak for everybody. We would like whatever resources you can send our way.
Yeah,
we would appreciate them. And we're going to turn it over to Adrian now.
Yeah. Hi, I'm Adrian. First, thank you, Rick. I've been taking a lot of notes from your presentation. Definitely want to include those in my program as well. So I'm from Miami, and I apologize for my voice right now. I have a bit of a cold, but I am from Miami, and I've been running a 10-week online program for children at our FQHC from about 7 to 12 years old. And we've been doing this actually since the beginning of COVID, because we were doing an in-person visit with MEND. I don't know if you guys are familiar with MEND, but it was a national program for children. And we were doing that, but it wasn't really working for our patient population. So we decided to switch it up, and we kind of created our whole new program online. And it focuses on three different areas. So it's a two days a week, for example, like Tuesdays and Thursdays, and one day is the nutrition day, and that would be with our dietitian as well. And during that visit, they'll actually learn how to cook with the dietitian. We'll have a recipe together for them, and we provide them with all the food they need. And virtually, they'll cook something together while also talking about a certain theme, like either nutrition labels, my plate, or different food groups. And then the second half of the class, or the second day of the class, is exercise and wellness. And I teach that day. And for the exercise, we'll do a variety of exercise like yoga, dance, or we'll even do like HIIT workouts. And I'll show them different YouTube videos too after each class, so they can repeat them at home. And we also incorporate a lot of wellness topics. So the first half of every class is wellness. And in that portion, we'll actually get, we'll do a topic like, we'll do a breathing exercise together. I teach them all breathing exercise, and then we'll focus on different topics like bullying or gratitude or kindness or positive affirmations. And we found it's really effective to bring up these topics with the kids. And we open it up for discussion too, and the kids can share their own experiences, like also with bullying, and be able to encourage each other moving forward. And so yeah, we provide them with all the materials they need for this course. So we'll have, like, when they come in originally, we'll give them a yoga mat, a soccer ball, a jump rope, everything they need for the exercise. And then also for the nutrition, we'll give them a cutting board, a kid-friendly knife, storage containers, measuring cups and spoons, just little things that they could do. And the kids love it. When they get that little bag, they get so excited for what's going to come. And then each week, we order all the food on Instacart, and we will, one or two people will just divide it up real quickly, and then we'll call the parents to let them know that their food is ready. And so anytime before the class, like they get like, I don't know, it's like 36-hour window, they can come pick it up before the class starts so they can virtually do it at home. If there's a parent or family that lives too far away, we'll actually give them a gift card of like $10 or $15 because the ingredients, it's very simple ingredients. So it doesn't cost a whole lot. We'll give them like $10 or $15 gift card, and then they'll just be responsible for picking up those groceries for their child each week. So at the initial visit, when we give them everything, that's also when we do their data collection, and I'll spend a good amount of time with them. This is the only in-person visit until the end. And we'll do surveys with them, including the Zeller survey, which was created by Cincinnati Children's, and it goes into how the child feels about themselves. And we'll also do the 5210 survey that we give to the parents to find out how many kids are eating fruits and vegetables, like how many fruits and vegetables they're eating, screen time, exercise, how much exercise they're getting. And at that visit, we'll also get all their labs taken care of. And then during the course, we have, and sorry, one more thing. We also send them home with scales and blood pressure cuffs. So we show the parents how to use the scales and blood pressure cuffs so that each visit, when we do our virtual visit, we can be calculating their blood pressure and just their vitals in general, and just include that into the visit. For their incentives, I actually use a scorecard. I don't know if it's shown on my screen. If you push next, if it'll pop up. No, maybe not. Okay. Oh, yes, there it is. Okay. So every week they get a scorecard, and they'll have a goal with the nutritionist that will coincide with their learning. So for example, drink 3 to 4 bottles of water a day. And I provide them with all the stickers, and this goes into the workbook that they get the first visit with me. And they'll get their scorecard. Every day they follow their nutrition goal, they get a sticker, or if they do 30 minutes of additional exercise, or if they do their breathing exercise, they get a sticker. And we really try to make this family focused. So every time a parent or guardian joins them, they get an extra point. And then at the beginning of every class, I say, pull out your scorecards. And in the first 5 minutes, the child that presents to me the most stickers, they get a gift card. And I send them a gift card virtually, like to Target, to their parents' email. And that gets them each week trying to do the goals we're talking about. And also during our class, to also get more family oriented, at that first visit, I take notes on who's in the family. So who's going to be at home when they're doing this class? Do they have like a 4-year-old sister? Do they have a cousin that takes care of them? Is grandma going to be there? And I write their names so that during our classes, we're including them even if we're not billing for them, we're including them in every part of the way. So next slide. It's our program is referral based. And so we have about 7 pediatricians and PAs where I'm at. And so every provider that's referring will just refer to our program. And about 2 to 3 weeks before the program, we'll call them up and we'll get the appropriate because we do 2 different programs. I should have mentioned that. We do a Haitian Creole program and English, and then a Spanish and English program. And that is just because our patient population is primarily Spanish and Haitian Creole here in Miami, Florida. So we'll divide them up and then we'll add them to the program, and we'll do that initial visit with me. And something I forgot to mention on the last slide was that we also do a final party at the end. And that's another incentive for them to come in. So after they've done this whole 10-week program, learned a lot from each other, they get a chance to meet each other in person. So they all get to come together. We do like a water balloon toss. We do relay races. They get gift cards, but most importantly, we get all our data again. So while they're all together, we pull one kid at a time aside, and we do the surveys again, their weight and vitals again, and we do the surveys again. So some of the challenges that we've had through this program would be getting those weekly vitals. It can be tricky. You're calling the parent like, hey, you forgot to give them the vitals, and they're trying to like take their vitals during the exercise, which obviously blood pressure is going to be a little bit high. We'll actually call them the day before. So we'll call the parent the day before and say, hey, tomorrow morning before you leave for work and your kid leaves for school, just write down what their weight and blood pressure was. So then when we call you at work, we can get that information. And that has helped. The other thing would be program completion. Just like Rick was saying, retention is really hard. So when we first started this, we would have like 25 plus kids in our visit. And by the end of the program, we only have 5 or 6. To combat that would be that initial visit that I just explained. So I really make sure that they know their expectations, what's expected in the program, the times. So sometimes it takes that in-person visit, even though they've been told on the phone several times what time the program is, from 4 to 6 at Tuesdays and Thursdays. When they come in, we find out they have other arrangements or aren't able to like be in the class because they have sport or something else going on. And so we're able to kind of weed out more people that way so that we know they're more committed. And then also just weekly reminders and the incentives I've already mentioned. And then billing and coding, how we're getting paid for this. We actually, like Rick said, we haven't had a whole lot of pushback from insurances. Almost a lot of it does get covered as a visit. So the nutritionist, unfortunately, we have not been able to figure out how to get that covered. Insurance doesn't pay for that. But the weekly visits with me, every other week, it is reimbursed, but I bill every other week. So I guess insurance, it's every 14 days we can get billed. And I just include their comorbidities because most of them do have comorbidities, even the children. So when I do the labs at the beginning, I find that the child had, hyperlipidemia or the high hemoglobin A1C, and we'll include that. If for some reason they don't have anything, then usually the diagnosis of obesity due to excess calories is like E66 also works. Post-program follow-up, actually, we're working on this summer. So for the last 2 years, we're going to bring all the kids in that we've seen and bring them all together again for a 4-week course to see how much they've retained and how we can dive deeper. So I know that was a lot. In 10 minutes, I didn't have that much time. So any questions?
That was fabulous, Adrienne. And I think our viewers would like probably another just question answer with both of you as a special session. So maybe we'll be able to arrange that. Meanwhile, people want to know if you're billing under a group or individual code. And then I think question two is, I think I've confused people because I thought your session, it says 4 to 5. So I was thinking it was twice a week for an hour, but can you just clarify?
Yeah. Sorry, I said 4 to 6. It's 4 to 5 twice a week.
Twice a week for an hour, but you only bill every 2 weeks.
Yes.
And then how many children, what's your limit in your number of children in your group?
25 is what we start off with. And usually that ends up being 18 to 20 when we actually start the class.
Okay, that's big. And then people are wondering what your outcomes are. And also there's different comments in here about like where some people work, it would only work at night or whatever. I'm sure that's different. Locally, you have to adapt. But people are wondering how that got funded and they're giving you lots of praise. But yeah, can you talk about how you got it funded?
Yeah, I mean, we did get a grant and that helps with the funding, but most of us that it actually does not, the grant covers a lot of the costs, but we do this within, so I'm still seeing patients all day, and then I just do this for an hour a day, and the same with the nutritionist, it's just an hour, and then everybody else, like the staff that's putting together the bags and the food, we're just doing this in between patients. So it's not it actually does not take very long to do.
That's impressive.
And there was, what was another question?
About outcomes. What are your outcomes over the past 2 years?
So one thing I found, it's hard with kids with their weight and BMI because they're also growing. And I'm also only looking at it for 10 weeks. But for example, this last session, almost every child, we had 12, their A1C went down. So most of them, you know, their A1C was not elevated over 5.7, but maybe it was like 5.5. And when we checked it again, it was 5.2. So almost every child, that's the one result I've seen that has been kind of consistent.
That's impressive. I would say not rising is huge, right? In terms of all the data that we've seen. And then Jessica Wallace, our colleague, reminded us that they'll be talking about group pediatric healthy weight interventions during our Module 5 session, and that Fit Family Club is part of the COMMIT program that's funded by the CDC and offered through NAC. So that's how Adrian came into our landscape, and we're so glad that you did. We are going to be short on time. This was exactly what I wanted with this class. Good. Have you had any pushback on exercise, on the term exercise? People are using the word activity with some of that. Any thoughts on that?
I personally haven't had any pushback. I try to let it be their own. And so to like at the beginning or halfway through the class, I'll ask what they've liked. And so if they really liked yoga, we'll just add another yoga day. If they really liked dance, we add another dance day, or ask them what they want to learn. Like one time, 2 of the kids really wanted to learn basketball. And so we did, for exercise day, we learned some of the rules of basketball, and then we did a workout with the basketball.
So I love that you're actually collaborating with the families around what they want rather than just giving them a set menu. So you've got a potluck happening at your place. Also, as a food question, people are wondering about culturally variable recipes. Of course, we would always encourage that, and how people have felt about the food.
So for the food, that's why actually we decided to kind of make our own. And our dietitian has created all the recipes. So to use the foods that we use kind of down here in South Florida, because it is a high, especially Caribbean population. So to make sure it's friendly to the different cultures we see here.
All right, people would like the recipes, so that's a question for you, Adrian. We're going to try to gather everything in this chat in terms of what people said they would appreciate getting and send that. If Liz, if you can go to the next slide. I think it was on kind of what was confusing to people, what is possible for you. Dr. Reifenberg's little prescription that he sends just in case people are interested is a nice example of what you can do in 1 minute, right? We've had some great examples of what you can do in 15 minutes in an office visit, and then the longer time in the 26 hours. And then just remembering, like, what's your goal at your health center? Is your goal health? Is it BMI change? Is it fitness? Is it disease prevention? And how are you communicating that? And how is that also your family's goal? So letting people, again, collaborate just like they did on the activity they chose. Next slide. And I know we're at time for those of you in clinic and stuff, but our next module is Module 4 on gathering the community. And we'll again have some wonderful FQHC peers who are going to help us on that. I'm excited about hearing from them. And if any of you are doing some of these things and implementing changes, we'd love to hear about it when you come back. And then, as Jessica noted, our last session, so next will be session 4. Session 5 is, we're calling a feast, and it will have hopefully plenty of interaction and opportunity for us to catch up on anything that those of you are missing. Feel free to email us, let us know what you're feeling like you're missing. We want to respond, whether it's in between times or during the modules. Thank you so much. Next slide is the CME, I think. yeah, there's resources, you'll get them, and then the CME. So on the slides, you'll see the scorecard, so you could print it off and do it. All of the slides